For centuries, medical education was built on the study of male anatomy. This approach established male physiology as the standard for understanding human health, creating lasting gaps in medical knowledge about women. This episode examines how this male-centered foundation developed and its consequences for women's healthcare. Segment 1: Early Anatomical Studies and Dissections. Medieval and Renaissance medical education relied heavily on dissection to understand human anatomy. However, the bodies available for study came primarily from executed criminals, deceased soldiers, and hospital deaths, populations that were predominantly male. Cultural and religious restrictions often made female cadavers unavailable for anatomical study. This practical limitation meant that medical knowledge developed almost entirely from male anatomy. As a result, doctors learned about organs and body systems by studying male specimens. The heart, liver, brain, and other organs were understood through male examples. This knowledge was then assumed to apply universally to all humans, regardless of gender. This approach created an incomplete foundation for medical understanding, as it was based on only half of the human population. Segment 2: The development of medical textbooks. As medical knowledge expanded, it was systematically recorded in textbooks that became the standard educational materials for medical schools worldwide. These textbooks reflected the male-centered bias of the anatomical studies they were based on. Medical illustrations featured male anatomy almost exclusively. Disease descriptions and treatment protocols were developed from observations of male patients. The texts presented male physiology as the human norm. When women's anatomy was mentioned, it was typically described as a variation from the male standard rather than as equally valid human anatomy. This framing reinforced the idea that male bodies represented normal human physiology. These textbooks were used for decades or even centuries, ensuring that multiple generations of physicians learned medicine through this male-centered perspective.
Segment 3: How medical schools taught anatomy. Medical schools incorporated this male-focused approach into their curricula. Students spent extensive time studying human anatomy, but the anatomical specimens and teaching materials were predominantly male. Cardiovascular, respiratory, and nervous systems were taught using male examples. Even when studying organ systems that differed between sexes, women's anatomy was often treated as a specialized topic rather than integral to understanding human physiology. This educational approach had psychological as well as practical effects. It reinforced the perception that male anatomy represented normal human anatomy, while female anatomy was exceptional or complicated. What was considered normal? Male cardiovascular patterns, pain responses, drug dosages calculated for average male body weight, and stable hormonal patterns that provided a predictable baseline for medical study. Even male heart attack symptoms, typically chest pain, became the standard that medical students learned to recognize. Female anatomy, by contrast, was labeled complicated. Menstrual cycles were seen as disrupting research rather than representing normal physiology. Hormonal fluctuations made women unreliable research subjects, and pregnancy was treated as a complicating condition rather than a normal biological function. When women experienced different symptoms, like jaw pain or fatigue during heart attacks instead of chest pain, these were often dismissed as atypical or psychological rather than recognized as legitimate female presentations. This framework taught generations of medical professionals that male bodies were the uncomplicated norm, while female bodies were complex deviations that required special consideration, if they were considered at all. Students graduated believing they understood human physiology when they had primarily learned about male physiology. This misconception followed them throughout their medical careers. Segment 4: The assumption that male equals universal. Over time, the medical profession developed the assumption that medical knowledge derived from male subjects applied universally to all patients. This seemed logical given that most research and education focused on male physiology. Treatment protocols developed for male patients were applied to female patients without modification. Diagnostic criteria based on male symptom patterns were used for all patients. Medications tested primarily on men were prescribed to women with the same dosing guidelines. However, this assumption overlooked significant physiological differences between men and women. These differences extend beyond reproductive anatomy to include variations in drug metabolism, immune response, cardiovascular function, and pain perception. The universal application of male-derived medical knowledge led to gaps in understanding how diseases affect women and how women respond to various treatments. Segment 5. What this meant for understanding women's bodies. The male-centered approach to medical education left significant gaps in understanding women's health. Beyond reproductive medicine, many aspects of female physiology remained poorly understood or completely unstudied. This knowledge deficit had serious clinical consequences. Women's symptoms were often misunderstood because they didn't match the male-based patterns that doctors were trained to recognize. Heart disease provides a clear example. For decades, heart attack symptoms were understood primarily through male presentations, crushing chest pain radiating to the left arm. Women's heart attacks often present differently, with symptoms like nausea, back pain, or extreme fatigue. Doctors trained to recognize male patterns often miss these atypical presentations. Similar patterns occurred across many medical conditions, leading to delayed diagnoses and inappropriate treatments for female patients.
Segment 6. Examples of how this affected diagnosis and treatment. The male default in medical education created specific problems in clinical practice. Emergency medicine provides numerous examples of these disparities. Women presenting with chest pain were often misdiagnosed because their symptoms didn't match the classic male pattern of heart attacks. This led to women being discharged from emergency departments while experiencing cardiac events. Pharmaceutical research conducted primarily on male subjects meant that drug dosing and safety profiles were not well understood for women. Women often experience different responses to medications, including unexpected side effects or reduced efficacy. For example, sleep medications like Ambien stayed in women's systems much longer, causing dangerous next-day drowsiness and car accidents. Discovered only after years on the market. These knowledge gaps meant women were essentially guinea pigs for medications never properly tested on their bodies. Mental health treatment was also affected, with conditions like depression and anxiety understood primarily through male presentations. Women's symptoms were sometimes dismissed as emotional problems rather than legitimate medical conditions, often attributed to menstruation, hormones, or the outdated concept of hysteria. This meant that serious mental health conditions like depression, anxiety, or PTSD were written off as women just being too emotional, instead of being recognized as real medical issues requiring proper treatment. Surgical procedures developed using male anatomy as the standard sometimes proved less effective or more risky when performed on women. For example, heart surgery techniques and devices were designed for male-size hearts. Knee replacement implants were designed for male bone structures, causing poor fit and higher failure rates. And basic surgical instruments like stents and pacemakers were sized primarily for male bodies. Women experience higher complication rates and longer recovery times because surgical techniques hadn't been adapted for differences in female anatomy, muscle mass, and healing patterns. Segment 7. The persistence of this bias through centuries. The male-centered approach to medicine persisted for centuries, even as other aspects of society evolved. Women gained political rights and entered many previously male-dominated professions, but medicine remained largely unchanged in its fundamental assumptions. Several factors contributed to this persistence. Medical institutions remained predominantly male, from students to faculty to administrators. The people making decisions about medical education and research had been trained in the same male-centered system. When physicians observed that women responded differently to treatments or presented with different symptoms, These observations were often dismissed as exceptions rather than patterns requiring systematic study. The male default had become so deeply embedded in medical thinking that it appeared scientific and natural rather than historically contingent. Segment 8. How this mindset shaped medical research. The male default extended beyond education to influence medical research methodology. When researchers designed studies to test new treatments or understand disease mechanisms, they typically included only male subjects. Researchers justified this approach by arguing that male subjects were simpler to study, as they didn't have to account for menstrual cycles or pregnancy. They also believed that results from male subjects would apply to all patients. This research bias reinforced the educational bias, creating a cycle where lack of knowledge about women's health led to continued exclusion of women from research, which perpetuated the knowledge gaps. The consequences extended to drug development, surgical technique advancement, and disease understanding. Most medical knowledge was based on male subjects, though it was applied to all patients. Segment 9. The long road to inclusion in women's medical education. Despite systemic exclusion, some women fought to enter medicine and contribute to medical knowledge. Elizabeth Blackwell became the first woman to earn a medical degree in the United States in 1849, though she faced rejection from multiple schools before being accepted. Other pioneers followed, including Marie Elizabeth Zakrzewska and Rebecca Lee Crumpler, the first African-American woman physician in the United States. These women faced significant discrimination, but gradually expanded opportunities for others. Women's medical colleges were established in the late 19th and early 20th centuries to provide education when mainstream institutions remained closed to women. These included the New England Female Medical College and the Women's Medical College of Pennsylvania. World Wars I and II created opportunities for women in medicine as male physicians served in the military. Political changes, including Title IX in 1972, further increased women's access to medical education. By the 1970s and 1980s, women were entering medical schools in significant numbers, beginning to challenge the male-centered foundations of medical education and practice. Conclusion. The establishment of male anatomy as the default for medical education was not based on scientific evidence, but on practical limitations and cultural assumptions. The consequences extended far beyond anatomy textbooks, influencing how diseases were understood, treatments developed, and medical care provided. Understanding this history helps explain many of the gender disparities that persist in modern healthcare. While significant progress has been made in including women in medical education and research, the legacy of the male default continues to influence medical practice today. The next episode will examine how the age of scientific progress in the 18th and 19th centuries, while bringing remarkable medical advances, continued to build upon and reinforce these male-centered foundations, further widening the gap in medical knowledge between men and women. If you enjoyed this video, don't forget to like it, subscribe to the channel, and share it with your friends.